My name is Patrick Piper. I work with the California Prevention Training Center, and we are one of CDC's capacity building and training providers. And it's my pleasure to join you this morning if you're on the West Coast, and this afternoon if you're anywhere east of Nevada. I think I got that right, east of Nevada. It's afternoon, so good afternoon to you. This webinar has been produced to support the important goals of the CDC in their response to the National HIV/AIDS Strategy and high-impact prevention. As well, we're presenting this information to further our collective mission in reducing the gaps in the HIV prevention and care continuum. In today's webinar, we'll be reviewing 3 types of interventions: behavioral, biomedical, and structural. This webinar has been produced as an effort through the Capacity Building Provider Network, which is made up of many capacity building assistance providers throughout the country. And the CBAs, as we're referred to, provide training to health departments, CBOs, and healthcare organizations. We also provide technical assistance to those same 3 categories of agencies. So there are many types of determinants. We're going to go, right into this. And to better understand how behavioral, biomedical, and structural interventions work, it's important to kind of understand the spectrum of determinants that affect health. So many frameworks have been used to describe these determinants. You may have heard of ecological systems theory or various social ecologic models, and they all basically use a comprehensive, holistic perspective that include factors that are internal to the individual and also external. So internal factors include individual level determinants, and anyone who's been in the field of HIV prevention is probably familiar with this because traditionally this is what we've spent a lot of our time focusing on. And these determinants include behavioral and psychosocial factors. So those are things like family dynamics, ability to communicate, skills, things like that. And external factors, again, those factors that are external, they're not within the individual's control, include things like what we call the social determinants of health. External factors can be categorized into 3 general categories that we often refer to. So we have community level factors, and that would include things like social norms or cultural beliefs. On the organizational level, we consider things like access to services or availability of products. And on the much larger societal level, we're looking at big factors such as the impact of policy and law and the impact that those have on health-related behavior. So it's important to note that one type of determinant alone often does not influence health or health outcomes. We need to be looking at them together, and they are often working in concert to affect health. So this, I understand this slide is somewhat busy, but let's just try and walk through it together. And we're just going to use, we're not going to use all of these columns. We'll refer to each column, but we're only going to use one section of each. And I'm going to try, here we go. So hopefully you can see my green arrow here. So this is kind of illustrating the way that social determinants may affect individual determinants, which may impact individual behavior. So in this example, we're looking at stigma. So stigma is the social determinant, and stigma specifically within the transgender community. And we could follow stigma through any of these pathways. I'm just going to use one example for the purposes of today's example. So let's start with physical and emotional and sexual violence. So, we all know that stigma plays a big role in one's acceptance in society, and that can often lead to physical violence, emotional trauma, and sexual violence perpetrated upon the people that are being stigmatized. So as a result of this violence, often that can lead to low self-esteem or poor mental health. Also, stigma is not only, when you internalize stigma, it's not only from individuals in the community or community stigma. There's also something called institutionalized stigma. And these are stigmas that are placed upon people from the organizations that hold access to the services that they may need. And so coupled with the internalized stigma, it may make people feel like, they have no choice in being able to access these services, and therefore they may not choose to access services even though they desperately need them. And so we're calling this low service uptake. So as you can see, as a result of stigma, that moves into, human rights issues, which lead to emotional issues on the individual. And because of these, people are reluctant to access services. And so they may not be able to get medical services, psychosocial or support services, or services that are going to give them knowledge and skills to protect themselves against HIV. And so as you can see here, the outcome is really quite daunting. Becoming infected with HIV may seem inevitable. Again, you can make a similar kind of pathway with any of these types of things, and it's going to lead from the social determinant to the risk behavior, which is going to lead to HIV infection. So this is really giving us kind of a starting point, giving us information of how we may choose to intervene. And so thankfully, a lot has been done to mitigate these outcomes. So behavioral and social science, medical sciences, they have yielded a wealth of information on approaches that have been proven effective in many aspects of health and wellness. So if you think about things like smoking cessation programs, to vaccinations, to access to condoms, these approaches are known as behavioral, biomedical, and structural interventions. And so here's kind of a framework that we use. In these three realms, they combine to make up a system of prevention services. And these prevention services work in tandem to promote and support positive health outcomes. In today's HIV prevention world, with high-impact prevention, these three realms of interventions are, being supported by the Centers for Disease Control and Prevention, and that is a result of what was called for in the National HIV/AIDS Strategy. And of course, you are probably familiar with the CDC's High-Impact Prevention Initiative. And so here is where you can get more information on what we're talking about, and that is through the Compendium of Evidence-Based Interventions and Best Practices for HIV Prevention. And there are chapters on risk reduction, medication adherence, and linkage to and retention in care. And here's a website that you would be able to get more information on these types of interventions. But as we move forward today, I'm going to turn it over to Bobby McCaffrey of the University of Rochester to lead us further into this discussion. So thank you, Bobby.
Thank you, Patrick. I appreciate that. So now we're going to take some time to discuss selecting behavioral interventions. And first, we'd like to take a look at what behavioral interventions are. Now, basically, behavioral interventions are designed to help persons either reduce behaviors that put them at risk, such as having sex without condoms or sharing injection drug equipment, or hope to increase protective behaviors. For example, increasing condom use or disclosure, increasing skills around negotiation of condoms, that kind of thing. Today we'll take a look at some terms and definitions. We'll talk a little bit more about behavioral determinants and intervention requirements. We'll take a look at resources to assess agency capacity, touch briefly on adaptation and what is expected if adaptations are to be used. And then focus a bunch of time on CDC-supported interventions. Now, not all of the interventions that are currently supported by the CDC are named in the 17-1704 FOA. So care should be taken when thinking about the interventions that agencies are looking to implement if they are funded through that FOA. Most funding opportunity announcements will describe which interventions are to be funded with those dollars. We will spend time today describing the interventions that are specifically named in the Prevention and Essential Support Services section of the 17-1704 funding opportunity announcement. So at this time, Cindy, if you wouldn't mind, please launching my first poll. We are interested, that's actually Pat's poll. Great. So we're interested to know if, for folks who are on the call, is your organization currently delivering any behavioral interventions or referring clients to behavioral interventions? So go ahead and click your answer. We got 6 lucky clickers. Okay. Just give it a few more seconds. Okay, so we've got half the folks who are on that have gone ahead and responded. So if you can go ahead and broadcast that. All right.
Sorry, did that not show up for everyone?
I didn't see it, but it's easy enough because for folks that actually decided to click, 100% of them are showing that they are either themselves delivering or are referring clients to some kind of behavioral intervention. And that was about half of the folks who are logged on right now. So for folks who are delivering or referring to behavioral interventions, if your agency is actually implementing an intervention, then you probably have gone through some kind of a selection process in order to decide which intervention to deliver. And for folks who are not themselves yet, or their agencies are not themselves yet delivering an intervention, this information will hopefully be helpful today. So just a few terms and definitions as we move forward. We're going to talk, if you hear us talk about risk behaviors, those would be behaviors that result directly in HIV transmission, such as sex without condoms or sharing needles and works for injection. And of course, mother-to-child transmission is a risk behavior. However, that is not a behavior that is typically addressed in behavioral interventions. We may also talk about risk factors, which really are the behaviors and contexts in which HIV is likely to be transmitted. So these would be things that have an effect on whether or not a transmission happens or a risk happens. For example, drug use that is not injection drug use. It doesn't directly transmit HIV, but increases the likelihood of transmission. Behavioral determinants is something that Patrick touched on earlier today, and we'll discuss a little bit more in the next slide. And that is something that these are addressed in behavioral interventions, and they also can be an important decision maker when it comes to selecting a behavioral intervention for use with your target population. So the behavioral determinants that are typically addressed in HIV and STD prevention behavioral interventions are things like that are listed here on the slides: knowledge, attitudes and beliefs, etc. And the activities of behavioral interventions are designed to influence these determinants. So for example, a lot of times these will overlap. You could have a person who lacks knowledge about the fact that sex without condoms carries risk for HIV. Or they may not know that rates of HIV are high in their population, in their community. So if they lack that knowledge, then their perception of personal risk for HIV may be very low, and that may influence their decision as to whether or not they use condoms when engaging in sexual activity, which can have an effect on putting themselves at risk for HIV. Behavioral interventions seek to change these behavioral determinants by increasing knowledge, having an influence on attitudes and beliefs, increasing perception of risk, etc. Some behavioral interventions also work on social norms, can offer social support, and spend time helping clients to think about their self-image, improving their skills, and increasing their confidence or self-efficacy. So each of the behavioral interventions that we'll discuss today addresses a certain combination of behavioral determinants. And knowing which behavioral determinants are relevant to your population can be helpful in selecting an intervention. Within each of the behavioral interventions, there are certain requirements. Core elements of an intervention are parts of the intervention that are thought to explain why the intervention has been effective. And those things are not to be changed if we hope the outcomes to be the same, which really is why the interventions are supported. So for example, if you have an intervention that in study showed that people who went through the intervention increased their condom use, you wouldn't want to change the parts of the intervention that are thought to have been responsible for that behavior change. And those things are outlined as core elements of the intervention. Key components of the intervention, sometimes also called key characteristics, are crucial activities or delivery methods that are needed for conducting the intervention, but it is acceptable to change some of those, and sometimes is necessary to change them in order to tailor the intervention for appropriate use. One example relevant to this FOA might be with regard to the age range. This FOA is specifically looking at services for young persons, ages between 13 and 29, and so it is potential that there might have to be some tailoring done around, pictures, which might be used in marketing, might need to go with a younger picture. And that is acceptable because those are not core elements. The idea of adhering to the core elements and the internal logic, or what makes the intervention successful, is what we call fidelity to the intervention. And it's important when working with some of these behavioral interventions to try to maintain fidelity, again, so that the outcomes that were had initially are able to be replicated in the program. Now, for each of the interventions that is supported by the CDC, there are certain tools that are available, and we will talk more about this in a moment when we look at the slide where the resources are listed. But some of the tools that are available are, for example, the Agency Readiness Assessment. This is where there's a checklist for each intervention so that you can go through and look and see, does this look like it would be right for my agency? Does this look like what we would need for our intended population? Do we have the resources that we need, the physical space resources, the staffing resources, the financial resources? It's kind of a step-by-step checklist to be able to go through and assess the readiness. Do you have it? Can you get it? Or do you not have it and you can't get it? In addition, agencies need to specifically look at whether or not they have buy-in from stakeholders, from internal staff, from community partners, and in support of the FOA, specifically if there are other requirements there for resources that need to be looked at. Finally, the idea of skills specific to each intervention. For the supported intervention, CDC also supports training and technical assistance for any agencies that are funded to deliver these interventions. Now, in order to make the interventions the most well-suited for populations, there may be some adaptation needed. And this is a process of modifying the key characteristics and components without competing with or contradicting the core elements or eliminating the core elements and the internal logic. This can be very, very important for cultural and linguistic appropriateness, as well as for marketing, recruitment, and retention. Now, any of the behavioral interventions in the CDC compendium can be adapted, and the standard party line has been that they can be adapted for use with transgender populations. However, the funding opportunity announcement 1704 specifically names behavioral interventions that grantees would be expected to use. And so careful attention is to be paid to those expectations. And we'll continue to talk about that as we move forward. This is a screenshot of the CDC's resource for behavioral interventions, supported behavioral interventions. And the URL is shown here at the bottom, www.effectiveinterventions.cdc.gov. And there's a drop-down menu for high-impact prevention, and you would click for behavioral interventions. Each behavioral intervention that the CDC supports is listed by name, and when you click on each name, it will show training resources and registration information for training. And that's also where you will access the planning tools, the agency readiness assessment. For many of the interventions, there are implementation plans and implementation summaries. You can also find the logic models for each intervention, research information, and other resources having to do with each of the interventions. So in addition to the behavioral interventions, there are sections for medication adherence, other biomedical interventions, structural interventions, social marketing, and a lot of additional resources. So from here, we're going to get into looking at some of the interventions that are supported by CDC for use, which may or may not be supported in the 1704 FOA. CDC's supported behavioral interventions for persons with HIV include CLEAR, which is an individual-level intervention for persons older than 16 who are either HIV positive or HIV negative. Okay, so in this case, this intervention you will actually see on several different slides and can be implemented successfully in different populations. Healthy Relationships is a group-level intervention specific for persons living with HIV. Partnership for Health is a clinic-based intervention. Willow is a group-level intervention for adult women living with HIV. And Project START. Now, Project START was not initially studied among persons living with HIV. It is intended for use with people who are being released from a correctional facility and returning to the community. However, its use with persons living with HIV is now approved. Continuing with more CDC-supported behavioral interventions for persons living with HIV, we see Promise, Community Promise, D-UP, Empowerment, popular opinion leader, and connect. Now, D-UP and popular opinion leader and empowerment were not originally studied among persons living with HIV. However, they are approved now for use with persons living with HIV. Community Promise is a community-level intervention for either HIV positive or high-risk HIV negative persons. D-UP specifically is a community-level intervention designed for and developed by Black men who have sex with men. Empowerment is a community-level intervention for young gay and bisexual men of diverse backgrounds. Popular opinion leader is a community-level intervention, and Connect is a couples intervention can be used for either HIV positive couples or HIV negative couples. Now, for CDC-supported behavioral interventions for persons at high risk for HIV, some of these we saw in the previous slide, D-UP and Community Promise and Popular Opinion Leader. In addition to those two, we also have Many Men, Many Voices, which is a group-level intervention for both HIV and STD prevention for Black gay men, as well as Personalized Cognitive Counseling, or PCC. PCC is a testing intervention for repeat HIV, people who have been tested for HIV, who are repeat testers who have engaged in unsafe behavior since their last test. Continuing with CDC-supported behavioral interventions for persons at high risk for HIV. Again, we see empowerment, which we saw previously. Sister to Sister is a supported intervention, although it is not named in the 1704 FOA. Safe in the City is a video intervention. It is a 23-minute video which is shown in STD clinic waiting rooms. Voces, which is a group-level intervention for persons who have arrived for testing in STD clinics. And Testing Together, which is the intervention formerly known as Couples HIV Testing and Counseling, or CHTC, which is another testing strategy designed for two or more persons who are in or intending to be in a sexual relationship who are tested and receive their HIV results together. So at this point, we wanted to ask what questions folks have. I do see there is one, although I can't see the whole thing.
Hi, Bobby. This is Adam. The question is, do any of these interventions have materials that come in Spanish?
Great question. Yes, there are a few. Specifically, there are full intervention materials in Spanish for voices, and also for Connect and for healthy relationships. And I do believe that there are several that are have partial. There are several that have training, but not necessarily implementation materials. Many of these interventions are in the process right now of being translated into Spanish. So that is definitely information which you can find by going on to the website that I mentioned previously, www.effectiveinterventions.cdc.gov. I see
Bobby,
that.
It looks like we have a follow-up question. Is translating a program into Spanish an accepted form of adaptation as long as the other elements are unchanged?
Yes, in fact, I don't know that that would even be considered an adaptation. And that would be something for which CDC would certainly offer guidance. It's always better rather than to set off and try to translate materials internally, which can be very time-consuming and resource-consuming in terms of cost. Always best to check with CDC because it is something for which there is a lot of attention, and there are many programs across the country who've already engaged in potentially translation activities, and so no sense in reinventing the wheel. Great. What other questions do folks have?
It looks like those are all the questions at this time, Bobby.
Okay. And so, Cindy, if you want to go ahead and launch that second poll that we discussed, the HPAT poll. All right. So recall that just underneath the block that says Fundamentals of Grant Writing Training Series, there is a link to the HPAT. And I know that I recognize several of the names of participants who went ahead and did their HPAT yesterday, and I thank you very heartily for that. But if you've joined us and have not done your HPAT survey, please go ahead and take a moment to click the link and fill out that survey so that we collect all of the data that we need for our webinar today. And we appreciate that very much. All right, so now I'd like to pass things on to Corey Doniger, who will be discussing biomedical interventions today. Yeah.
Okay, thank you, Bobby. I'm here. Good afternoon, everyone. My section will be addressing biomedical interventions, and it will be building on some of the things that you've heard already from Bobby and from Patrick around behavioral interventions and structural interventions. So the definition in terms of what is a biomedical intervention, this is really the CDC definition, and you can find this on the Effective Interventions website that Bobby previously mentioned if you click on biomedical interventions on that drop-down menu that she showed. The formal definition here is the use of medical, clinical, and public health approaches designed to moderate biological factors and physiological factors to prevent HIV infection, or to reduce susceptibility to HIV, or decrease HIV infectiousness, or the ability to pass the infection on to a sexual partner or needle-sharing partner. So biomedical risk reduction interventions then include antiretroviral medications that persons with HIV can take to prevent transmitting HIV, as well as optimize their own health. Also include antiviral medications now that are used for people who are uninfected to prevent them from acquiring HIV. Examples obviously would be PrEP and PEP. So this section will address the following points in terms of a biomedical intervention, overall effectiveness, types, and we're going to talk a little bit about health disparities and how that relates to BMIs. Utilization of BMIs and how the utilization is affected by behavioral and social determinants and interventions, and the role that CBOs can play in helping to increase access to biomedical interventions and reduce disparities. Then we'll talk about the CDC-supported interventions that have to do with BMIs, funding considerations, and finally the need for partnerships or service agreements with a variety of different kinds of organizations and agencies in one's community. So just starting first looking at effectiveness, biomedical interventions are highly effective in general. So for example, you see the first one on the top is treatment for prevention. So this is the utilization of antiretroviral medication for persons living with HIV. And in a very important study, which has been repeated, reducing viral load through taking these medications for persons living with HIV has been shown to reduce the chance of transmitting HIV by 96%. So this really was an important finding that sort of launched the idea of treatment as prevention for persons living with HIV. More recently, there have been studies about PrEP, taking antiretroviral therapy, or called pre-exposure prophylaxis, to prevent getting HIV. And so there have been studies done in discordant couples, in heterosexuals, and then I want to focus here on the PrEP for MSM. One study known as IPREX is pretty familiar, and we want to focus on that a little bit. So when you look at the PrEP for MSM, the overall effect or effectiveness for everyone who was enrolled in that study reduced HIV acquisition by 44%. However, that included participants in the study who were taking the medication, who were taking PrEP, as well as participants in the study who were not taking PrEP for a variety of reasons, or were taking it infrequently. And so when they did a subset analysis of just those men who were taking PrEP consistently and who had actually PrEP in their blood, levels of PrEP in the blood levels, the effectiveness was 92%. So it reduced the chance of getting HIV by 92%. So really, adherence is the big factor. In CDC terminology and decision making, overall the effectiveness of PrEP is said to be over 90% if a person is taking PrEP as prescribed. And then we have STD treatment. STDs enhance both the chance of getting HIV as well as the chance of transmitting HIV to a sexual partner. And so STD testing and treatment does reduce HIV transmission. The last two are microbicides and vaccines, which are not FDA approved yet in the United States. But the message here is, in general, the biomedical interventions are highly effective if used as prescribed. And so we'll look at the continuum of care with HIV along the spectrum and look at the BMIs as to how they connect to the continuum of care. So PrEP and PEP on the left here are BMIs for people who are at high risk but not HIV infected. I'll talk a little bit more about them in a few minutes. HIV testing is, of course, on the continuum, but also now much more focused on integrated screening, which is also highlighted in this current FOA, the 17-1704, because the testing is now to be expanded to include STD testing as well as viral hepatitis testing. And then this is not in the FOA, but vaccines. There are STD vaccines for MSM and transgender persons, specifically hepatitis A and B vaccines and vaccines against human papillomavirus, which are highly effective in preventing those STDs. Then we have linkage to care. We have retention and re-engagement in care. In the CDC's compendium, these two are linked and referred to as LRC, linkage, retention, and re-engagement in care, LRC. And so there are many effective LRC interventions in the compendium, which we'll discuss in a few minutes. Medical adherence is obviously part of the BMI, and there are, again, effective interventions for medical adherence that are emphasized in the FOA. And all of these for persons living with HIV and AIDS are to achieve the goal of antiretroviral treatment as soon as possible after diagnosis to decrease viral load. And to make viral load undetectable is the overall goal. As I said before, this reduces the risk of transmission to others and optimizes the health of the person living with HIV. I just want to mention what this has to do with disparities. You know, we all have been working for many, many years in HIV prevention, and in spite of a lot of effort and many effective interventions, health disparities in terms of rates of HIV and STDs persist. And the BMIs really have the potential to significantly reduce these disparities. And so the populations for which there are disparities in STD rates and HIV are listed here, but I, of course, want to focus on the first two. MSM, and in particular, we know disparities are highest for young men of color who had sex with men. Also, in terms of transgender people, disparities are highest for young transgender people. Disparities also exist for women of color, for heterosexual men of color, adolescents, substance use, users, sex trade workers, and people who are or have been incarcerated. But this FOA is focusing on the first two. So the idea is that because of the high effectiveness of the BMIs, there's potential to significantly reduce these disparities in these priority populations that we just mentioned. However, that requires people accessing health care, basically. And so we know from a lot of other biomedical interventions that have been effective but not accessed that there are significant barriers to health care. Patrick mentioned this a little bit earlier in terms of stigma. So you can see that the barriers to health care include social determinants, lack of insurance, limited access, stigma, racism and homophobia, transphobia, poverty, etc. So these social determinants come into play, as well as behavioral determinants for our priority populations. There may be lack of knowledge. PrEP awareness is increasing, and PEP awareness, but is not as high as we'd like it to be at this point. So there may be lack of knowledge about some of these BMIs. There may be some negative attitudes about accessing health care, possibly related to previous negative experiences within health care. There may be perceived benefits which are low because someone may not realize how effective a particular BMI can be. I think the other thing that's important is social norms. In many communities and populations, people aren't necessarily used to going for preventive services. So sometimes the norm is I only go to a doctor or a healthcare provider if I'm sick. And so we want to look at how we can impact on some of those norms when we're talking about accessing PrEP, for example, which is taking a medication for a condition that you don't have. So it truly is a preventive service. So addressing barriers to health care is necessary in order to optimize the effect of BMIs on our priority populations. So how can CBOs work to address some of these barriers and to impact on the disparities? The CBOs, of course, have access to the population. And so the idea, of course, is for the CBOs to act in terms of their services and their staffing to serve the role of bridging, addressing barriers, identifying barriers within their communities, and linking, or through service agreements, formally linking their clients to healthcare settings where they can access these BMIs. That also may include providing some of the BMIs on site. We'll talk about that in just a minute. So specifically in terms of the CBO role of influencing healthcare behaviors and health promotion behaviors for their clients and communities, CBOs can provide education and counseling. For example, very much education and counseling around PrEP and PEP is needed in many communities and populations. Also, talking about disclosure, it is well known in the literature that Black men of color are the least likely to disclose their MSM status compared to white or Latino MSM. And so being able to disclose and tell your healthcare provider that you are a gay male, for example, is very important in terms of accessing biomedical interventions such as PrEP or even some STD vaccines. So helping clients feel comfortable disclosing is a very important role that CBO staff can play. Also, obviously, recruitment is very important, recruiting for these various BMIs, navigation for linkage to care, retention re-engagement in care, for medical adherence, for HIV care, and then obviously navigation to PrEP and PEP as well. And of course, there is the option of providing some BMIs on site within a CBO organization, such as HIV and STD testing, and also hepatitis C testing at this point. And the other role that CBOs can play to increase access to BMIs is really helping to do something CBOs have done very well for years, which is working to reduce stigma and provide essential support services. And that can be done through community mobilization. Many CBOs have implemented community mobilization interventions for MSM around PrEP, for example, expanding peer services, peer support, helping their clients navigate to insurance and enroll in insurance plans. And then linking to other essential support services, mental health, substance use treatment, housing, transportation, employment, et cetera, as examples. So in terms of selecting the BMIs, for persons who are at high risk for HIV, high-risk negatives, CBOs can provide navigation for all of these services that we mentioned. Now, linkage to PrEP and PEP, and obviously supporting adherence to PrEP and PEP actually would be an important service. Ongoing testing for STDs and HIV, MSM are recommended to have STD testing at least every 6 months if there's ongoing risk behavior. And in many recent criteria, medical criteria and guidelines, it's being discussed that there should be screening for STDs every 3 months for sexually active MSM at risk. I wanted to mention, because this is in the FOA, that the screening for gonorrhea and chlamydia does need to include rectal screening as well as urine screening, which is essentially testing the urethra. Because in studies it's been shown that half the time, if an MSM has gonorrhea or chlamydia, the infection is in the throat or the rectum and not in the urethra, in the penis, in other words. So the urine screening alone is not adequate STD testing for MSM. And so the FOA is emphasizing rectal screening, which can be done with the client obtaining the rectal swab themselves, and then the site submits that for testing. So that's very important to have what they call extragenital screening, not just in the penis or urethra, but in the rectum and the throat. MSM also in transgender persons need syphilis testing, and this is often, again, done every 3 months, but at least every 6 months. Syphilis epidemic is increasing for men who have sex with men and is very much of a concern. And sometimes there have been cases where syphilis has been acquired repeatedly over time. So the frequent screening is very important. Accessing STD vaccines, as I mentioned, hepatitis A and B and HPV are all recommended for young MSM. And then, of course, navigating for the behavioral interventions that Bobby mentioned, and then for partner services for STD and HIV partner services. For persons with HIV, in terms of BMIs, again, it's navigation to some of those same things. Access to HIV treatment, though, being a priority for linkage, re-engagement, retention to care, and medical adherence. And then ongoing STD hepatitis testing as well. Again, at least every 6 months, if not every 3 months, for persons who are receiving HIV care. This has been recommended for many years. However, studies within HIV clinics show that less than half of MSM who are getting HIV care are actually getting ongoing STD and hepatitis screening. So this is an important role for CBOs to play to advocate and help their clients ask for regular STD screening if they're going for HIV care. Same thing with syphilis testing, necessary at least every 6 months, if not every 3. Vaccines if they haven't been previously obtained. And then, again, partner services and behavioral interventions for persons living with HIV. So CDC-supported interventions for the linkage, retention, re-engagement, and care would be ARTIS. There are other LRC interventions in the compendium that Bobby mentioned earlier, and so you could look at the list. It's just that this one is the one that CDC is supporting through training and technical assistance. Likewise, for medical adherence, there are many medical adherence interventions that are in the compendium of effective behavioral interventions and best practices for HIV prevention. The ones that are supported by CDC include these 4, and there is online training available for these 4 interventions, again, through the Effective Interventions website that Bobby previously showed. I wanted to mention, and this is, again, something that we see in the FOA, the importance of the collaborations and contracts or partnerships that CBOs need in order to link persons to these biomedical interventions. And so there obviously needs to be relationships with healthcare organizations, both HIV clinics and other primary care settings, even though PrEP has been, up until this point, often given through accessing HIV clinics. The HIV care providers are sometimes giving PrEP, but really in order to maximize PrEP access, primary care providers, nurse practitioners and PAs and MDs in healthcare settings such as community health centers, STD clinics, adolescent clinics, family planning, etc., are often now implementing PrEP services. So those relationships are very important. Likewise, relationship with your local health department around their HIV, STD, hepatitis prevention services. And so some clients, for example, who are accessing PrEP, even though they may be getting PrEP from their primary care provider, may choose to go to the STD clinic in their local health department for their STD screening every 3 months. That's required if they're taking PrEP. Likewise, important to have connection with health insurance enrollment sites so people can be accessing Medicaid, especially if you're in a state where there's been expanded access to Medicaid and or other insurance plans through health exchanges. Some sites are getting insurance navigators on site so that clients can be enrolled on site. And then again, connection and service agreements with providers of other essential support services that we previously mentioned. So I think in terms of considerations, specifically with PrEP and PEP, we mentioned before there needs to be those collaborations we just discussed, but also think about the idea of having a document that defines the roles and responsibilities. So if you're in a collaboration with a CBO, CBO is in a collaboration with an STD clinic and maybe some other healthcare organization, it's important that there be written roles and responsibilities for each of those three entities. What's the role of the healthcare organization? What's the clinic or the health department going to do or provide? And what services will the CBO be responsible for? In that regard, sometimes staff are co-locating. So sometimes CBO staff may be in an STD clinic helping to do PrEP education and counseling and enroll persons in PrEP services. Another consideration is for information sharing. So if you're in a collaboration with a healthcare organization, they have responsibility for protected health information under HIPAA, and so there needs to be protocols for how could that information be shared on a particular client between the healthcare organization and the CBO staff. And then lastly, a plan for monitoring and evaluation of the navigation services. The same kind of thing for HIV, linkage, re-engagement, retention to care navigation. Same kind of thing, except this time it would be with an HIV clinic. So again, the CBO would have a connection with a collaboration with an HIV clinic, with a health department DIS perhaps, doing partner services, disease intervention specialists, and again, trying to think about processes for how you're going to share information. In this case, for retention or linkage, we'd want the CBO to be able to know if someone missed an appointment, one of their clients missed an appointment, or stopped altogether accessing HIV care. And so how will that information be shared between the clinic and the CBO who's providing navigation services? Again, sometimes there's co-location of a CBO staff within an HIV clinic, perhaps. And again, often then same thing, writing protocols for how to share client-level protected health information and plans for how you're going to monitor and evaluate your services. So that's sort of an overview of behavioral interventions. I did want to ask one polling question. I'm sorry, biomedical interventions. I did want to ask one polling question. Does your organization currently provide screening tests for gonorrhea, syphilis, and chlamydia for MSM and transgender persons? Okay. Great. And it looks like about maybe 2/3 of you do, and about a third not at this point. So that is an important consideration, obviously, as specified in the 17-1704 FOA. Thank you. So now,
Okay.
before we go on, other questions?
Hi, Patricia. I don't have any questions at this time, but let me encourage all our attendees to please type your questions in the questions feature there, and we will have time to answer them at the end of the presentation. Thanks.
I do just want to mention one thing that I didn't emphasize since I have a minute here. There is now a rapid syphilis test. This is done with a finger stick, and it is FDA approved, and it is CLIA waived. So CBOs can implement rapid syphilis screening as they have implemented rapid HIV testing through this CLIA waived rapid syphilis test. Okay, so now I'd like to turn it over to Patrick again, and he will address more details around structural interventions.
Great. Thanks, Pat. And I want to engage in a short little collective activity, and I know it's getting late in the day on a Friday, especially if you're on the East Coast, but if everybody will just take a minute and wherever you are, stand up and stretch. We're just going to take a minute just to stand up wherever you are. If you could see me, I'm in my little cubicle here in Long Beach, California doing interpretive dance. So that's how I keep myself, healthy during these webinars. So if everybody will just stand and stretch, we've got a little bit more to cover with regard to structural interventions. And then it's the weekend. Okay, well, I'd like to thank my colleagues, Bobby and Pat from the University of Rochester, for giving us an excellent overview of behavioral and biomedical intervention. And the last type of intervention we're going to cover this afternoon are structural interventions. So one of the structural interventions that is currently being supported by the Centers for Disease Control is condom distribution. And so thus you have this image here of a condom dispensing machine. And we'll talk more about, why that was chosen and why that is a structural intervention in a minute. But basically, condom distribution as a structural intervention assumes that people have the knowledge at this point. Most people have knowledge. Most people can, figure out how to use a condom correctly if they haven't mastered it. However, lack of appropriate access may be really what's the issue. You've all been to the drugstores and the condoms are behind the counter and you have to ask the pharmacy and then they have to do a price check, and it can be a real intimidating experience, particularly for young people, to access condoms. But just imagine if you had these condom machines everywhere, for example, at your laundromat, and right after you bought your box of soap and your dryer sheets, you pop over and you buy your condoms and whatever else you need. Now that is what I call convenient. So that's kind of what we're talking about when we're talking about structural interventions. These are interventions that are operating, again, on more of a large level, on a macro level. They're looking to affect laws. They're looking to create or change physical structures, to influence social organization, operating procedures, anything that's affecting the environment or society on a large level. And again, what distinguishes these from behavioral and biomedical interventions is you're really moving at an external level outside of individual control. And so a person, may not have any direct involvement in the actual intervention, and yet they will be influenced by its effect. They also often require an innovation, so sometimes it'll be a new kind of thing that's going to be happening, or they require changes, like we mentioned, in policies, laws, bigger social structures, so they tend to take longer to fully implement. They also require collaborations between many sectors of the community, so it's not just the HIV community, service providers that we're necessarily working with now. You may have to go to the Department of Education, to the Housing Department, to the Employment Department, various stakeholders who are going to be able to help you with implementing your structural interventions. So we just wanted to take a minute to remind us again the definition of the social determinants of health, and that is because structural interventions are often the level of intervention that will directly impact these social determinants. And so if you think of social determinants, and this is from the World Health Organization definition, these are the conditions in which people are born, grow, live, work, age, and I've also seen end play. And these determinants are often shaped by money, power, access to resources on many different levels, so global, nationally, even local levels. And often they're the result of policies that are made, many times without the express input of the communities they're serving. So Kamara Jones, Dr. Kamara Jones, who is now the president of the American Public Health Association, has described social determinants as responsible for health inequities. And we can think of health inequities, according to her, as unfair and unavoidable differences in health status seen within and between groups and populations. So that's what we're doing often when we are implementing structural interventions. This visual is just to kind of wrap our heads around the intensity and the impact of behavioral, biomedical, and structural level interventions. That's what the L is for here. So if we look at this, and for the purpose of this slide, we're defining intensity as per unit, like how much investment per unit served is this going to take. And so often these structural level interventions, you could see they're not as broad as far as intensity. So I'm not spending, a half hour with each individual member of the community in trying to help them in positive health behavior change. The further down you go, and you can see, you can kind of envision the white arrow as being biomedical, because biomedical really does cross in between structural and behavioral interventions. But the further down we go on the left arrow, you'll see that as we get into the behavioral interventions, they're much more intense and have much more intensity per unit served. So if I'm spending, again, a half hour with each individual person, that is a major consideration as far as time and resources go. So structural level interventions tend to be less intense. Behavioral interventions are much more intense. Biomedical somewhere in the middle. Now, if you turn that triangle around and you look at the impact, you can see that for all of the intensity on the bottom there that we're putting in to behavioral intervention, the outcome and the impact of the intervention tends to be relatively small. And that's because there are millions of people in the U.S. and how one by one, how much change can we really hope to see? Whereas if you move on up the triangle and you begin to implement and work on a social structural level, you're going to have much more reach, and the impact will tend to be longer lasting and more sustainable. And we'll talk more about that as we move forward. So structural level interventions, and this is according to work that was done by Blankenship and her associates, and she refers to what's called the 3 A's. And I kind of like this because it's very simple, and hopefully it'll be simple as I describe it to you all. But basically, structural level interventions are really seeking to impact, the first A is availability. So are things available to begin with? Can people even get condoms in community settings? Can people get PrEP or get antiretroviral treatment? You think of people living in rural areas, and if you have to drive 100 miles in order to get to the nearest clinic to even access these types of services, maybe you don't have a car. Even if you do have a car, can you afford gas? You all know the stories. it could be a lot in the way of people being able to access these services, which brings us to the next, going backwards, which the next level would be, and these aren't in any particular order, but the next level would be acceptability. And that is, are these, I'll call them innovations, is what you're trying to serve acceptable to the communities that you're trying to serve it to? And so if you think about social norms regarding PrEP, if the MSM community, I think, in the U.S. is the largest group of people that are accessing PrEP right now. But imagine if the gay community, did not support PrEP. Imagine if everybody said, oh, no, they're going to give you HIV if you take PrEP, or, there's a conspiracy behind it. Then how likely is it that people in that community are going to take PrEP? Not very likely. And we've heard, throughout public health, we've heard stories of this really being a barrier. So is it acceptable? And structural interventions are seeking to influence that as well. Or changes in laws. Can we distribute condoms in schools? Can we have comprehensive school-based sexual health education? And then finally, accessibility, which I was referring to earlier. So something may be acceptable in the community. So kind of getting back to my example, if you're in a rural area, well, it may be acceptable to be on antiretroviral therapy. The community may support that. It may be available, but it's 100 miles away, and I don't have a car, or I don't have money for gas. Therefore, it's not accessible. And so being able to bring the services to the places where the people are at that need them is the consideration. And all of these are examples of where structural interventions can step in and be pretty effective. So I would like to take a minute real quick here, and you'll notice that there's a box here, and I think Cindy's going to bring a not a polling box, but a box where you'll be able to type. Yeah, there we go. So I'd like to think about, for you to think about, availability, accessibility, and acceptability. And can you think of an example of an HIV intervention that is addressing one of these today? So take a minute, just type your answer into this chat box here. And again, can you think of an example of an HIV intervention that is addressing availability, acceptability, or accessibility? So I'll give you a minute to think about that. So hopefully more people will begin typing. Again, think of an HIV intervention today that you're aware of that is trying to increase availability, accessibility, or acceptability. Getting some good answers here. And we'll take about 15 more seconds. Great, and I see Veronica's still typing, so we'll look forward to, there we go, perfect timing. So yeah, thank you for those of you who answered that question. So certainly we are seeing that PrEP, with a PrEP program, you're running into it's going to answer any of these 3 A's. So in some places it may not be available. Other places it may not really be accessible. And I think, as we move forward and we all do our work, it's becoming more acceptable. I know that, there are still parts of the medical community that PrEP is very controversial. And it's, that's one of our challenges, is trying to make it acceptable amongst certain medical communities that it's okay to prescribe PrEP. So, our work is focused on that section of the A's. Outreach and community mobilization. Often when you're doing outreach and you're mobilizing a community, you are actually working to make something acceptable. Social marketing campaigns are often used in those types of interventions, and the reason that we use social marketing campaigns is really kind of to rally people behind whatever it is that we're trying to address. Artists certainly is really focused on making things accessible, making treatment accessible, helping people to access early intervention, so on and so forth. Testing, again, in my mind, could fall anywhere in these three A's, depending on what it is that you're looking for. And then Veronica, yes, well said. I've often heard PrEP be described as similar to birth control in that, birth control is still controversial. How many years has it been available? But back in the day, it was very controversial. And why do you need birth control? Because you're going to go sleep with people? Oh, why do you need PrEP? Because you're going to go out and sleep with people? Well, yeah, I just might. And if I do, I want to be, feel protected and do what I feel is sexually responsible. Imagine that. So again, structural interventions are seeking to impact anywhere along these three A's: availability, acceptability, and accessibility. So some examples of HIV-related SIs. You have condom distribution, as we talked about, really aimed at increasing availability and access. Social marketing, and again, we use that example, trying to get norms around PrEP is a good thing, and it should be taken up by anybody who feels like they need it. Integrated services, so really integrating HIV and STD screenings, integrating tuberculosis, viral hepatitis. Why should I have to go to 2 different clinics or 3 in order to get all of these tests done at the same time? So you're looking at service integration there. Job training, microfinancing programs, and that's where, you were offering some sort of a small grant, if you will, for people to begin their own businesses, and that's operating on the economic level. We know that low socioeconomics often have negative health outcomes. They're correlated with negative health outcomes. Housing. And so, how in the world are you going to be able to keep something in a refrigerator or, adhere to your medications if you're homeless? I mean, those are the barriers that are so big that a lot of people feel like they can't do anything about, and yet in numerous studies with numerous different health conditions, lack of housing is correlated with very poor health outcomes. And so, we emphasize this to say, I could put all of my effort in a behavioral intervention and teach someone, that you have to take this pill every day around the same time, but yet if these other barriers are in existence, how likely is it that I'm going to be successful in that? Probably not likely. So you need a combination approach. And then finally, changing surveillance data policies, and this is kind of what we are seeing with the data to care interventions that are being supported now from the CDC. And this is really looking at some of the confidentiality laws and who can have access to some of this classified information in order to bring people to care and treatment. So those are just some examples of structural level interventions as implemented with HIV-related conditions. We all know this continuum, and so what I'd like us just to kind of think about is this is the continuum in HIV care, and it is from the updated National HIV and AIDS Strategy, and so the most recent I'm aware of is 2012. And these are changing, and they seem to, all of these columns seem to be going in the right direction, meaning we are closing these gaps slowly but surely. But you'll notice that the gaps get larger as we move from, being diagnosed with HIV to being virally suppressed. And because of the biomedical studies that Pat referred to, one of the goals that we have is if somebody is living with HIV, we know that getting the viral load suppressed not only has better individual health outcomes for the person themselves, it also has community-level outcomes. And the city of San Francisco is doing a great job at showing that by lowering the viral level on a community level, meaning, a majority of the community now has low viral threshold, the chances of transmission are greatly reduced. And so that's kind of some of the rationale for high-impact prevention, and why we're seeing more done with biomedical interventions these days. But just consider what else, and if you think of the social determinants of health, these things that are outside a person's control, if you look at these last three bars here, the engaged in care, prescribed antiretroviral treatment, or virally suppressed, and this says prescribed, I'm going to add adhering, adherent to the antiretroviral treatment. Think about things like access, larger barriers. Why do these gaps exist? And how much of this gap can be attributed to the social determinants of health, not individual behavior? And so this is just one example to walk you through kind of how these social determinants may play out with regard to a gap in the continuum. And for the purposes of this example, the gap in the continuum here that we're looking at, my arrow, is adherence. Oh, I don't know what happened to my arrow, but the gap in the continuum is no adherence to medication. And so adherence to medication, that second from the last bar, is the bar that we're looking to close. So here's Tina, and Tina is a young lady living with HIV. And so she lost her job. And so, that's an economic determinant. She doesn't have any money for rent. As a result, she gets evicted from her house. So, she kind of lives in an expensive part of town. She gets evicted from her home, and so she moves into another city or maybe another side of the city that doesn't have the services that she once had. And so now she's forced to look for shelter, and as she's looking for shelter, she doesn't have a home, and she's homeless. Her meds that she had, and everything was going great when she had her job and she had her home, have run out. And now she has no idea where to find medical care. She's in a new town. She's feeling overwhelmed because of all of these other priorities in her life. And as a result, she falls out of care. And the fact that she's not in care also means that she's not adhering to medication. Now, you could intervene anywhere along this pathway, and you would be most likely intervening on a on a structural level, trying to address economics, housing, or access to services. And you would be doing a structural intervention addressing a social determinant. The impact of social determinants on really large or macro level factors is that they do have a lot of influence on these isms, these large things that, have taken, we still have racism, we still have homophobia, we still have poverty. And, this country's been in existence for over 200 years, and still we're battling with these same old things, but that doesn't mean that they can't be addressed and can't be influenced. And, we've seen that. These structural interventions do take a little bit more time. When we're talking about structural level interventions on the macro level, certainly it will take more time. But again, we can't stress enough that the impact and sustainability of these interventions are much more longer lasting. So, think about interventions that have addressed racism and think about how that's been done. With regard to homophobia, I mean, one of the recent biggest structural interventions that I can think of is gay marriage. Many, many studies have shown that gay marriage acts as a protective factor for gay men, and that it can actually have incidence impact with regard to disease. So it can actually affect, whether or not somebody gets an STD or HIV. And I'd also want to share just one example from the state of Iowa. Through their community planning and a group that was originally working on hepatitis, a concerned group got together and they began to say, at the time Iowa had the strictest or one of the strictest HIV criminalization laws, and you could get, sentenced to 25 years in prison if you had sex with somebody, even consensual sex, even if you did disclose your HIV status and you were serodiscordant. If you were prosecuted, you could face 25 years in prison. And so they rallied behind that. Now, it took 8 years, but in 8 years, they managed to overturn the law, and now Iowa has a completely new law on the books. And if you think of the implications of that, we all know that, if I have to fear going to jail, by learning my HIV results and learning that I may be HIV positive, well, it's much easier for me to not have to worry about that or think about that. And if I don't know, you can't throw me in jail for what I don't know, right? And so you can see how having that structural barrier in place really impacted everything else that we were trying to accomplish, and certainly that we're trying to accomplish in closing the gaps in the continuum, and that being the diagnosis and testing in the first place. So I think throughout this, this webinar, none of us are saying that one of these intervention approaches is better than the other. Like I said in the beginning, they all work together. They work in tandem, each with its own focus, but they're working together in order to promote and sustain positive health outcomes for everyone. And so I think I have a polling question. Do I have a polling question? Yeah. Okay, so, and is it closed? Yeah, there we go. And so structural interventions, and take a minute, if you will, to answer this. Structural interventions include changes in policy, adherence to antiretroviral treatment, and access to PrEP. 2, changes in policy, providing mobile testing and access to PrEP. And 3, changes in policy, counseling, and access to PrEP. So go ahead and take a minute. What do you think? Okay. And it looks like we can pretty much, there we go, close that. Great. Yes, so changes in policy, again, is a structural level intervention, providing mobile, remembering those 3 A's, and whoops, it moved away. Okay, well, that was my question. So number 2 was the correct answer for those of you who were wondering that. So what questions does anyone have? If you have any questions, go ahead, and I see one. Will the webinar be posted to, and I'm going to turn this over to my friends at the CPN. Will the webinar?
Yes, this is Cindy. It's our understanding from CDC that the recordings of each of, there will be another webinar as part of this series, and we don't have a date quite set for that, but there have been 3 webinars so far. This is the 3rd, and they will be posted on the CDC site as well as the CBER Provider Network website, and I put the link there up in the link pod. They're not there yet. We just need some final clearance, and we'll get those up and able for you to share them.
Thank you. And also, were we going to list our websites for the California Prevention Training Center and the University of Rochester anywhere?
You know what? I failed to do that, but I can get those links right up there while we're taking these final questions. And also, just so everyone knows, if you go to the SEBA Provider Network website, you can click on, I think it's the second tab over, where it says Find a SEBA Provider, and drop down, and all 21 SEBA providers in this network are listed there. And there's plenty of resources on that site as well. So let me try to get this up. But I'm sorry, Patrick, I cut you off.
Well, I just wanted to thank everybody for their time and hanging in there for a rather long webinar, and just, remind you that we are here to help with anything we can offer with regard to helping you be successful when you begin addressing social determinants or embarking on a structural level intervention. So thank you.
And we are past time, but we do have, I don't know if anybody wants to stay on for one quick question. Would you be willing to answer it, presenters?
Is that, can you explain again where to find the agency readiness assessment checklist? Yes, so if you go to effective interventions, all one word, all lowercase, effectiveinterventions.org, and I think we can put that somewhere as well. Effectiveinterventions.org will give you a list of all of the interventions that we've been talking about, and you can click on the intervention, and many, if not all, have the agency readiness assessment checklist.
Terrific. Thank you. And I am going to go ahead and add those websites you mentioned, and anyone who's not interested can go ahead and log off. But at first I want to take the time to thank our presenters today. It was a great presentation. We appreciate it. And thank all of you for joining us today. Again, I'm going to leave this open. Those links will be up in just a minute.